Welcome back. With me today from Hoag, more specifically the Jeffrey M. Carlton Heart and Vascular Institute, we have Peggy Morley. And Peggy, you are the nurse coordinator within this department, right?
Yes, I'm actually the nurse practitioner that works with the cardiac surgeons in the Heart Institute.
Well, welcome.
Thank you for having me.
Nice to have you on today.
Thank you.
So the main thing that we're going to talk about today is the minimally invasive approaches to aortic valve stenosis. So first, let's talk about what aortic valve stenosis is and the different approaches that we used to take compared to now.
Okay, so aortic stenosis is a degenerative disease of the aortic valve. Everyone has 4 heart valves in their heart. The aortic valve is probably the most working valve in the heart. It takes blood out of the heart that's oxygenated and diverts it into the aorta, which delivers it to our body and tissues, our organs. And then blood is reverted back to the heart once it's unoxygenated. So the aortic valve is the exit route out of the heart. Over time, as we age sometimes, in about 1 out of every 8 patient over 75 will develop some form of aortic stenosis. And what that happens, it's a narrowing of the heart valve, which prevents blood from moving out of the heart. So what the heart then tries to do to compensate for that is it will contract even harder and work harder to get blood out of the heart and into the body.
Now, I have heard before that when it comes to the valves that sometimes it's just something that's hereditary. It can happen. I don't know about the aortic valve the way you're speaking of it, but sometimes they just wear out. And what I'm asking you, is there some way you can prevent that, or is it just something that comes with aging?
It's typically something that comes with aging. There is a form of familial aortic valve stenosis, which typically will occur if someone has what we call a bicuspid aortic valve. Now, aortic valves traditionally have 3 leaflets that open and close. They're a one-way valve. Some patients are born with 2 leaflets. Those patients that have 2 leaflet valves, which we call the bicuspids, are prone to earlier aortic stenosis.
So this is something that it sounds like that it's not maybe lifestyle related. It's something that's a little more something you're born with, or
something you're born with. It's a degenerative disease of aging. So what happens over time is, everyone has heard the term hardening of the arteries. It's like hardening of the valves. The valves work very hard, and as blood flows through, oftentimes calcium deposits are put on the valve, which restricts its opening and closing.
What about ways to prevent it? Can someone do that?
No, and people get confused by thinking, oh my gosh, I grew up drinking milk, so that's why there's so much calcium on my valve. It just happens. Very rarely, if a patient has a infection called endocarditis, that can damage the aortic valve as well and make the leaflets either restrictive or what we call flail, where they are just incompetent.
So how do you folks first find out that someone has this condition? Or I guess let me reverse that. How does the patient, the person, know that something's wrong here? Or does the primary care provider detect something? What's the first few steps to figuring that out?
That's an excellent question, because we still do believe that there's a large cohort of patients out there that are walking around with aortic stenosis and don't really realize that they have it. Now, typically what I see in my patients is that at one time at either their primary physician's office or their cardiologist, someone has noted a murmur. And what a murmur is, when we listen to people's hearts, we listen to the valves opening and closing. And there's a certain sound that goes with that, that is normal. There's a definite sound to a valve that opens and closes that's restricted. And that's what we call a heart murmur. So that's one of the first things that a patient will be told, and they may not have any symptoms at that time. They could have had a heart murmur for 20 years, and now all of a sudden they're starting to feel tired, They walk upstairs, they might feel very short of breath by getting to the top of the stairs. They might start to notice that they have some swelling in their legs or their hands.
Okay.
And then in the later stages of aortic stenosis, we start to see patients complaining of chest pain, and or what we really get concerned about is syncope, which is they will pass out for unknown reasons.
Can this problem create a heart attack, of what we classically call a heart attack, or if it gets so restricted?
No, not a heart attack, because what a heart attack is basically is that the coronary arteries become restricted and are not delivering enough blood to the heart muscle.
Okay.
What the valve's job is to deliver blood to the body.
Okay.
So it wouldn't cause a heart attack, but in very rare cases, in late stages of aortic stenosis, if it goes untreated, someone can experience sudden death.
Oh, okay.
So that's what our main concern is.
Okay, let's talk about treatment. And over the last probably couple decades, the treatments have become less and less invasive, of going in and replacing that valve or whatever needs to be done. And that's good. I mean, that's it's amazing what has been done, and the way they come in with small instruments from different parts of the body and get up there. And so explain the what's done today.
Okay, but I'm just going to premise that with the fact that, again, it's a disease of aging, and statistically, about 1 out of 8 patients over 75, as I stated earlier, will have aortic stenosis. If it goes untreated, this is what I want to premise the treatment options with. If it goes untreated, a patient with severe aortic stenosis that may not even know that they have that, if they're symptomatic, about it's only a 50% survival rate in 2 years.
Wow.
So it's as bad as any metastatic cancer.
Okay.
So it must be treated, and it's a mechanical problem that has to be treated mechanically.
Okay.
So the gold standard traditionally has been open heart surgery, where we do a sternotomy, open up the heart, cut out the old valve, and put in a new valve. Now with the TAVR program, which is what I coordinate at Hoag Hospital, we can achieve the same results by inserting a catheter through either groin or making a small incision up just below the clavicle, and within 15 minutes deploy a brand new valve in over the old valve.
Wow. You don't even have to take the old one out?
No, we don't take the old one out. So what ends up happening is we go in with the valve that is crimped, and it's mounted on a balloon, and we blow up the balloon, which deploys the new valve in over that old valve, and the old valve gets pushed to the sides of the heart. And within
That's amazing.
15 minutes, they have beautiful blood flow through that valve.
This almost sounds, in a very, very simplistic term, it's like the people who go out and reline your piping in your house. They're not getting rid of the piping, they're quite literally pushing everything aside and creating a...
Right.
That's incredible.
Yeah, it is.
And it takes 15 minutes?
So the procedure, I tell my patients that they'll be in the room for about 2 hours, but the majority of that time is prepping and then waking the patient up. But the physicians, which is always a heart team, a interventional cardiologist with a heart surgeon, work together, and within 15 minutes from groin to replacing that new valve,
that's amazing.
Done.
So again, it seems to me the real focus here is someone who may have this condition, and to get the information that, yes, you do have this, we need to take care of this as soon as possible. Because the symptoms may, as you said, you could be walking around with this for quite a while and not notice it, right?
Exactly, and a lot of my patients are older, so they think, of course I'm going to get short of breath when I walk up the stairs. Of course I'm tired all the time. Fatigue is probably the #1 symptom that I see with my patients. Okay.
Are primaries at a certain age, and I don't mean the primary doctor, I mean they're seeing patients of a certain age, should they be in tune of looking for this at a consistent basis? I mean, are they going to pick it up just the normal, let me listen to your heart?
You know what? I work with my primary referral base is fantastic, and they're very smart. And one of the basic things with their physical exam is listening to the heart.
Yeah.
And the murmur of aortic stenosis is very, very unique and very evident, especially if the valve is tight. So they know exactly what to look for. And since now this technology has been out and commercially approved for about 7 years now.
Right, right.
And the primary physicians get to see their patients come back to the office after they've had this done. And literally, my patients will have the procedure on a Tuesday, go home Wednesday at lunchtime, and if they want to go out to dinner that night, they can.
Wow.
Versus surgery, where they'd be in the hospital for 5 days, maybe have to go to a rehab facility after that. They can't drive for 3 weeks.
That's amazing.
It is really, it's such a lifesaver.
Yeah, great. Well, I appreciate you coming on and talking about this. And if folks want more information, you can go to the website, Hoag's website, hoag.org /cardiac. Call 949-764-5871 if you want more information. And Peggy, great
So
great
nice
having
to meet
you on.
Yeah, please.
Thank you very much.
Thank you.
And hopefully we'll see you again.
Okay, I
All
hope
right.
so.
We'll be back.
Thanks.